Good evening, sir. First of all, I express my sincere gratitude to the chairperson and also uh, the organizing committee for conducting such CME, and I express my sincere gratitude regarding this. And let's come to the talk. De novo hospitalized heart failure patient impacting outcome. So around the world, 64 million people carry the diagnosis of heart failure. So it is very common, particularly as far as the hospitalization is concerned in cardiovascular
Sir, have you changed your slide? We are seeing your introduction slide.
emergency. So if you consider this de novo heart failure, if a patient come with heart failure and admitted in the hospital, they actually fall into two categories. Either in acute heart failure, that means they have no prior history of heart failure or cardiac dysfunction, or they are in the group like acute decompensation of chronic heart failure. So these two terminology even existed in the past, but these two entity has been studied significantly in the recent until recently. In a recent Ascent heart failure trial, these two entity has been studied and evaluated, and it showed that the patient with acute heart failure with reduced ejection fraction, they have a better prognosis. So de novo heart failure with reduced ejection fraction, what do you mean by this terminology? In different trials, particularly Ascent heart failure trial, Report heart failure trial, and other case series from Danish heart failure case series, they defined it different way. In commonly, we define de novo heart failure as the patient presented with heart failure without known prior history of heart failure. In other trial, they defined it as a without any history of heart failure or any history of heart failure within 30 days of hospitalization. So, when de novo heart failure means there is no history of heart failure or history of heart failure within 30 days of hospitalization. So, de novo heart failure and acute decompensated heart failure, it is a two different clinical entities. Underlying cardiac dysfunction is not present, or there is new onset of cardiac dysfunction that can be precipitated by other precipitating factor like infection, atrial fibrillation, and acute coronary syndrome that leads to acute LV dysfunction or LV systolic or diastolic dysfunction, pulmonary congestion, right ventricular dysfunction, and systemic congestion. So there is also disease progression. So de novo heart failure is a growing challenge, and it occurs when there is sudden increase in intracardiac pressure and myocardial dysfunction. De novo heart failure can be precipitated by most commonly acute coronary syndrome. So management targeted at supporting either pharmacologically or mechanically to stabilize hemodynamic stability and at the correction of underlying cause. So what are the critical characteristics of de novo heart failure? First, we consider how many of us attend such a patient, particularly in emergency. In different trials, the incidence of de novo acute heart failure is different. In Ascent heart failure trial, it is around 15 to 30%. In Report heart failure trial, it is around 30%. And in Danish trial, it is around 51% of patient of 11,000 registry patient. So in our experience, it is around 10 to 20% patient in our emergency department. They have a different clinical entity and characteristics features. They are more younger. They have a few comorbidities like diabetes, COPD, renal failure, obesity, or all these factors, and they are less likely to have prior myocardial infarction or coronary revascularization. Most important characteristics precipitating factor in this group is particularly acute coronary syndrome. Infection is less commonly precipitated this group of patients as compared to acute decompensated heart failure. So distinction of de novo acute heart failure, acute decompensated uh, chronic heart failure is very important that improve our strategical line and improve our treatment because they have a better prognosis in the long run. Mortality is different in both these groups. At 30 days, mortality is almost similar, 8 to 9%. But in long-term mortality, it is lower, particularly in de novo acute heart failure patient. It is around 22% at the end of 1 year and 72% at the end of 10 years. Whereas in acute decompensated heart failure patient, it is around 30% and 90% respectively. So in hospital outcome of de novo heart failure patient, mortality is around 4.7%, 6-month mortality 15.2%, ICU admission rate is 15.1%, and length of hospitalization stay is around 7 to 15%. Risk of readmission is higher in de novo heart HFrEF patient even with current heart failure therapy. Readmission rate is around 11% and 27% at the end of 6 months and 1 year respectively. So we need a better treatment therapy for de novo heart failure patient. So do you prefer AC inhibitor or ARB or ORNI in this group? There is little data, particularly AC inhibitor or ARB, particularly in de novo HFrEF patients. So there is no well-designed randomized trial, particularly if we consider mRNA like spironolactone or brifenol. Also limited evidence is there. Only single center study it showed delayed initiation of MRA is associated with significant increase in mortality versus initiation in hospitalization. In beta blocker, open label impact heart failure trial is there. It showed benefit of trend of benefit towards early initiation, particularly before discharge from hospital. It's better in comparison to starting after 2 weeks. So Sacubitril, valsartan or ORNI, this is the only therapy having robust evidence for in-hospital initiation of heart failure therapy supported by current guidelines. So this ORNI is recommended as a first-line therapy for decompensated acute de novo heart failure or acute decompensation of chronic heart failure. ESC recommended, so it should be started as a first-line therapy rather than AC inhibitor or ARB to reduce the short-term risk of adverse events and to simplify management by avoiding the need to titrate angiotensin converting enzyme first and then switch to sacubitril valsartan. Yes, it recommend no need to titrate angiotensin converting enzyme on first, then switch to sacubitril valsartan, and there is no requirement of checking plasma concentration of NT-proBNP prior to initiation of ORNI. So, what are the impact of ORNI in de novo hospitalized heart failure patient, particularly heart HFrEF patients? It reduces cardiac biomarker in de novo heart HFrEF patients. So, if you look at this chart, it is clear the proBNP level before initiation and at the end of week there is significant reduction in de novo HFrEF patient. It also helps heart failure patient with reduced ejection fraction stay out of hospital and live longer. Patient on ORNI had a significant lower incidence of composite cardiovascular death and hospitalization in comparison to chronic heart failure patient. It also reduces recurrence of heart failure hospitalization in de novo HFrEF patient. In acute de novo heart failure patient, there is 39% reduction. In prior chronic heart failure patient, there is 39% reduction versus 28% reduction in de novo heart failure patient. So there is 11% lower incidence of first heart failure readmission or cardiovascular death in sacubitril valsartan group in de novo heart failure patient compared to chronic heart failure patient. It also reduces the time to fast heart failure related rehospitalization and also cardiovascular death in HFrEF patient. And there is significant reduction, particularly 11% lower incidence to this fast heart failure, hospitalization, and cardiovascular death in comparison to acute decompensation of chronic heart failure patient. It also reduces all-cause rehospitalization rate in de novo heart failure patient, particularly HFrEF patient, and there is statistically it is statistically significant, and it is 11% lower incidence in all-cause rehospitalization rate in de novo HFrEF patient. So, what are the impact of ORNI in hospitalized patient of HFrEF patient without angiotensin converting enzyme or ARB? If patients are naive to ACE or ARB, there is 48% reduction of rehospitalization rate. If patients are getting ACE inhibitor or ARB, then switch to ORNI, there is 40% reduction of rehospitalization rate. Regarding cardiovascular death, if ACE inhibitor ARB naive patient, there is 46% reduction in mortality in comparison to 20% reduction of mortality if patients are getting ACE inhibitor or ARB. ORNI also reduces serious critical composite endpoint in ACE inhibitor ARB naive patient, and its reduction is 48% in comparison to 44% who have a prior exposure to ACE inhibitor or ARB. There is also significant reduction in NT-proBNP level in ACE inhibitor ARB naive patient, and it is around 28%. So how can we titrate the ORNI dose of ORNI in de novo acute heart failure patient with HFrEF patient? We have to start the dose 50 milligram once daily, then gradually titrate the dose and build up the dose up to 200 milligram per day over several weeks. So titration of dose, it also shown that in de novo heart failure patient versus prior heart failure patient, there is 11% greater achievement of target dose of ORNI at the end of 26% of the at the end of 26 week in de novo heart failure patient.
Sir, you have 1 minute left to conclude.
In and other guideline directed medical therapy like beta blocker and mRNA and all these group that can be also uptitrated with initiation of ORNI. So to summarize, acute decompensated heart failure or de novo heart failure is a known entity. They have a different clinical features. In hospital mortality is 4.7%. There is limited evidence for benefit of in hospital initiation of heart failure therapy. There is only robust data regarding ORNI, particularly initiation in hospital start of the therapy as far as ESC consensus guideline. So Sacubitril valsartan shows significant reduction of cardiovascular mortality and rehospitalization rate in de novo heart failure patient. And we can also uptitrate other disease modifying drug with ORNI. Thank you.
Thank you, Dr. Sarkar, for your wonderful presentation on ARNI. There is one question for you. With the DAPA heart failure data,
Yeah.
what would be, I know that it's not against an active comparator, whereas ARNI's trial was against an active comparator. But again, we have to keep in mind that in heart failure, we want to up titrate to the maximum dose, where
Yes.
ARNI becomes quite a bit expensive. So with the data, emerging data of dapagliflozin in non-diabetes heart failure patients, any change in your therapeutic regimen that might occur in coming years?
Yeah. And now we already have changed our day-to-day practice. We often combine all these disease modifying drugs. Particularly, there is four foundation of therapy, particularly either ACE inhibitor ARB or ORNI. Patient should receive a beta blocker or MRA or like spironolactone or epinephrine, and patient should also receive particularly dapagliflozin in all patients of chronic heart failure who are presenting who have a recurrent history of heart failure, particularly as far as HFrEF patient is concerned. So all patients of chronic heart failure with reduced ejection fraction should get all this drug like ORNI, beta blocker, MRA, and also dapagliflozin. So in
Thank
this way,
you.
we have
Yes.
changed our
Yes.
practice.
Okay. So